Welcome to the Sowing Seeds Specialty Series. My name is Amara Onya, and myself and Daniel are working behind the scenes with Alumni Affairs to put on this show. This has started with our past president, Osase, and continued with our current president, Nita. We could not be more excited to give you tonight's show on obstetrics and gynecology. So tonight we have a great panel of physicians who are here to answer your questions. So join me in welcoming our physicians. And just so you know, we also put on so many different Sowing Seeds specialty series throughout the year. So it's a year-long program where we provide resources on how to succeed as a pre-med student, as a medical student, and we'll touch upon everything from financial literacy to preparing to board exams and more. So make sure you're a national member by visiting the snma.org and signing up to stay in the know. So first up, we have Dr. Arumala.
Hi, everybody. Thank you for having me.
It is our pleasure. Thank you for being here. Next up, we have Dr. Cope. Thank you. Next up, we have Dr. Amarua.
Hi, everybody. Thanks for having me.
Thank you for joining us. And then lastly, we have Dr. Lewis, but when she gets on, we will be able to put her on the screen. So stay tuned. We have more coming. So with that, how about we get started with everything that we want to know about your background. So where did you go to medical school? Where are you now? How did you choose your particular specialty? Did you have any mentors in your field along the way? And what's your favorite thing about your specialty? So let me repeat that. Where did you go to medical school? Were you trained? And where are you now? How did you choose your specialty? Did you have any mentors in the field? And what your favorite thing about your specialty? So who would like to get started? Don't all jump in at once.
I can jump in if I can remember
Okay,
all the
great.
points. So hi, everybody. I am Okachi Amarowa, or UK for short. Let's see, starting with where I went to medical school. So I went to medical school at Columbia University in New York City. From there, I went to do my residency, my OBGYN residency at Brigham and Women's Hospital and Massachusetts General Hospital in Boston, Massachusetts. Went back to Columbia for my maternal fetal medicine fellowship. And now I have officially started, actually, you guys are like the first to hear this before a lot of my friends and family at UC San Diego as a maternal fetal medicine clinical faculty and women's reproductive health research scholar. So let's see, I think, how did I choose my specialty? I guess talking about OBGYN in general, and I'll try to keep it brief. My father is a physician. So as many of you know, it's not uncommon to see children gravitate either directly to or directly away from the path of their parents. And I happened to see the connection he had with the community, the longstanding relationship he had with people, and just the variety of things he did, and gravitated towards it. I'm the type of person who can get bored very easly. So I like to do different things. And the fact that I was afraid I wouldn't like surgery, but I happen to actually love the surgical aspect of it too. And so the fact that you can do surgery, outpatient visits, such a range of specialties and activities, and also be part of what is not just sickness and illness, but what can be a happy, healthy part of people's lives, is what made me ultimately settle on OBGYN. From there, like I said, I was very conflicted because I love the surgical aspect. I love laparoscopy. I love, outpatient visits, pap smears, your annuals. But I think what initially connected me was rooted in prenatal care and maternal care. And just seeing the way that's something that draws people in wanting to be pregnant, wanting to start a family exists, whether you're the healthiest person ever, or whether you have a congenital heart defect. And now with technology and medicine, we're alive long enough that these people are having babies. So I had to decide, could I imagine giving up surgery, or laparoscopy, I should say, kind of more minimally invasive stuff and those smaller procedures, or could I imagine having someone who's pregnant and having to refer them off? In medicine, there's always something you're going to have to give up if you want to be good at the things you do. And so ultimately, I said, with pregnancy, I can't imagine having those patients and walking them through that journey and having to refer them away. And I wanted to be good at the range of maternal care. So that's what landed me in maternal fetal medicine, and haven't looked back, no regrets, even though sometimes I still miss laparoscopy. But I try to stay connected to it and always possible. Anything I missed in what we're supposed to answer with my
Your mentors.
My mentors. Oh, thank you.
Yes.
So critically important. What's interesting, maybe not surprising, is all my mentors, my very close mentors who I'm still close with this day, happen to be Black women, for better or for worse. They don't have to be, but for mine, in medical school, Dr. Hilda Hutcherson, Black woman, Dean of Diversity at Columbia. In residency, Dr. Audra Meadows and Dr. Nawal Noor. Dr. Nawal Noor is Sudanese. Audra Meadows is a Black woman who's now at UC San Diego. And in fellowship, who literally catapulted my career, Dr. Cynthia Giamfi Bannerman. I was never the kind of person who I always thought was good at networking or good at connecting, which may fool you because I apparently am good at talking a lot. But that was never my strong suit. But I think the people who really have your best interests at heart and who gravitate towards you and you gravitate towards them, it's going to come naturally. And then you figure out how to be a good mentee, of course, but they have been critical in believing in me, directing me, and getting me, even my job now. Dr. Cynthia Giamfi Bannerman is the chair of Obstetrics and Gynecology here at UC San Diego. And one of the big reasons that even though I knew I wanted to come home to California, that I landed at UC San Diego. So, and I still keep in touch with all of them to this day.
That is wonderful. I love that story, and definitely not wanting to be just stuck doing one thing, but multiple different things and seeing your patients through. I think resonates with a lot of people. So lovely to hear that. Who would like to go next? Dr. Cope? Yes.
Yeah, can you hear me now? It's pretty good.
Yes, we can. Yeah.
Sure. Hello again. Sorry, I was muted on the introduction. I'm Zeb, or Dr. Cope. I went to medical school. I'm an osteopathic physician. So I went to LECOM Erie. My choice to do that was, honestly, I had never heard of osteopathic medicine until I had lived in Europe for a while. And I just like having some of the options for osteopathic medicine to do the OMT. And that actually helped me a little bit in residency. I ended up choosing OB-GYN because I felt like in some ways it was the most complete specialty, meaning it was a good reason to come to the hospital. You get to do lifelong care. You get to take care of a family potentially. You get cancer management. You get complex surgery. There's moments on the L&D that it feels like trauma. And then all the things that you'll go to the ER for. So I felt like it was the most complete specialty. With that being said, I think that something that happens a lot of times is imposter syndrome, and it's very prevalent in residency. One day you're a medical student, the very next day you're a physician. And quite frankly, for me, I didn't have that feeling of being a doctor, like I did something, I really helped something, until I had a Urogyn rotation. And it was a very, very, very simple procedure. We had this Hispanic lady come in, and she wasn't making eye contact in the clinic. And she basically was saying that she hadn't been able to see her son, who only lives like 2 hours away, because she had to use the restroom so frequently. We did a simple sling. This wonderful woman comes back. She's dressed in all white. Her hair's cut, dyed blonde. She's wearing heels, and she's like, "Papi, I'm all good. I feel so good now. I can go see my family." And I mean, just seeing the life that simple procedure did. And, I did that procedure. And I think that was one of the first times I felt like, I was a surgeon, I was a doctor on just a simple case. And then later on, really getting into the complex surgeries that you do with the robot or laparoscopically, I really enjoyed delving into that and being an expert among experts in those procedures. And then Urogyn, we don't do life-saving procedures, but we definitely do quality of life-saving procedures. And that feeling for me, when I can see like the light come back in someone's eyes, the life come back to them, it's pretty powerful for me. So that's why I ended up choosing Urogyn. And also, I felt that the lifestyle would be a little bit better than if I were still delivering babies myself. My mentors, there are three main ones that stand out. In medical school, the first one is Dr. James Blake. So I went to Lee Comp Erie for medical school. However, my last 2 years, clinically, I was in New York City. I was in Queens. I kind of knew I wanted to do OB-GYN coming even before medical school. It was on my top three. But I felt like when I went to my rotations, it was very difficult to not get kicked out of the room. And I think a lot of that is framed and, the nurses who are doing a wonderful job, they would just present it to the patient and they would say, we have this guy, he's a big guy, he's a really nice guy, because I'm a big guy. I am 6'8", I'm 6 feet 8 inches. So the big guy, big guy, he's a nice guy. And I think sometimes the way that they would frame it, the patients would be like, I don't want to, why are you introducing him like this? So I kept getting not having the opportunities to deliver. So I started looking elsewhere. I tried really hard to like orthopedic surgery. I really did. And it just didn't feel good for me. And I was kind of dejected, feeling like I didn't have a place to be. And then one day I'm on a rotation. Here comes Dr. James Blake. He looks like he's a linebacker for the New England Patriots. Just big dude, African-American man. And so seeing him and seeing his flow with his patients, and he actually took me aside. He said, I know as a medical student, it feels this way. Once you're on the other side, you'll have a lot more opportunities and it won't be that way. You just have to stay true to yourself, keep your patients first, and just be the best that you can be. In fact, be the best at all times. And so that was very powerful for me. It encouraged me to actually pursue OB-GYN wholeheartedly. My second main mentor is Dr. Sean Francis, who was actually my program director in fellowship. African-American man. He did his fellowship training at Mayo. And I think something I often hear in some of the mentors that mean the most to you, they drive you absolutely the craziest. So with him, when fellowship, it's a little bit different model, at least for my fellowship, it's more of apprenticeship model, meaning in residency, you're spread out. You're with this attending, this senior, this junior. In fellowship, as the attending goes, you go for the most part. And so you're attached at the hip for months at a time. And Dr. Francis demands excellence in everything that he does. And so I think a thing to keep in mind, that I had to keep in mind, is if they didn't believe you could do it, they wouldn't coach you to be better. They wouldn't push you to excellence if they didn't think you could get to excellence. And so that's at least what I tell myself. And it was tough, because it's tough being critiqued critically and feeling like you're failing sometimes, or not living up to someone's standard when you're trying to impress or live up to someone's expectations. But he did a great job of managing that anxiety, but also encouraging when necessary. And I'm extremely thankful for that. I'm sure I'll hear his words in my head for the rest of my life in the OR, critiquing how my hands are, where my shoulders are, how my elbows are. So did I hit all the points? Was that what everything I was supposed to say?
Yes, you did. Yes.
Perfect. Thank you.
Thank you so much. All I'm hearing is that we need those mentors who can see our potential more than we can in those moments where it could be very difficult to see, and to just continue to guide us in where we're going. And also to have those moments where the patients really define, like, this is where I'm supposed to be. Those are magical. So lovely to hear that. Dr. Arumala, would you like to go?
Yeah, I can go.
Yes.
Thank you, Dr. Dr. Ukachu. I had a senior with her last name is very similar to yours, Dr. Merway. And Dr. Cope, for sharing your story. Is encouraging me. And my name is Dr. Ruth Arumala. I am a board certified OBGYN. I started my medical school at Rowan School of Osteopathic Medicine. So I am a DO. I did my residency at Georgetown University Hospital, MedStar Washington Hospital Center. Did my first fellowship in Oklahoma, in Tulsa. It was a non-accredited, minimally invasive GYN surgery fellowship. And what that means is, just like Dr. Cope explained, I was attached to the hip with one person. Unfortunately, my my mentor died right after I finished my fellowship. So I was his last fellow. So I am his living legacy. And I went and worked for about 2 years. I owned a practice in Mansfield, Texas. I closed down my practice last July to go back to fellowship to completely change my career. I am a facial and general cosmetic surgery in about 12 weeks. So I'm finishing my fellowship in Seattle. So, wow, I don't even know where to start. The process of discovering yourself in the journey of medicine is really interesting. I think OBGYN affords you that because we have lots of unifying personality traits, but very different ones. And I love that about our specialty. So Dr. Kachu kind of talked about being a maternal fetal medicine doctor, where she's working with really high risk pregnancies. And I wanted nothing of the sorts. I don't even want to take care of pregnant women on a day-to-day basis. I'm really interested in women's lives, and however you define a woman, but women's lives outside of pregnancy. And how can I make it better? So I have a specialty in menopause. I have done the specialty for sexual dysfunction. I take care of women with abnormal uterine bleeding. And now I'm taking care of women in terms of their cosmesis and making sure that their breasts can be reconstructed the way they want them to be after childbearing. Because I think that the focus on women historically has always been around pregnancy and being able to birth alive. While I think that's so important, and I applaud my colleagues for taking care of that, I think that sometimes the other fullness of their lives get sort of pushed to the side. Are they enjoying their intimacy with their partners? Are they living a full life after 51 during menopause? I wanted to do that. I wanted to take care of those women. I wanted, after pregnancy, to revise your C-section scar. I wanted to make sure that you had the body that gave you the confidence that you can go out and conquer this world. Because as we know, we live in a very superficial world, in that what you see is what people judge you as. So a lot of people lose confidence as their body changes, which happens naturally. But I want to be able to rejuvenate and restore that. So that's why I went into cosmetic surgery. There are many other reasons. I actually started off my journey in medicine. You might not be able to tell that now. I don't have any makeup on, but I grew up with only pimples. Like, I didn't have skin. Like, from when I was age 8, it was just acne. And so my only doctor, when people talked about wanting to become a pediatrician, I didn't remember what my pediatrician did for me. I remember what my dermatologist did for me, because my dermatologist taking care of me, there's a phenomenon in which Black girls aren't given things like Accutane, because they suspect that Black women or Black girls are more sexualized and more promiscuous. So they don't offer us all the options, right? There are lots of papers written about this. But my older white male dermatologist thought that I deserved beautiful skin too, because he understood how it affected me psychologically. So I went into medical school wanting to be just like him. I went into medical school wanting to become a dermatologist. And as I went through the process, I realized that actually loved living in the OR. I loved everything about just being able to use my hands and my brain to really transform people's lives. And so through that process, I discovered OBGYN. So I went into OBGYN wanting to take care of women with fibroids. And my first mentor, his name is Dr. Gerald Burke. And I say he's my first mentor. There were other people that definitely influenced me. My mother's a physician. My mom used to be an OBGYN. She's a geriatrician now. And so she was obviously a major mentor, but she's also my mother. What happened is that Dr. Burke was a reproductive endocrinologist that didn't do any infertility. He just did reproductive surgery. He was Catholic and he had a lot of ethical issues. So my exposure to him was living in the OR, doing a lot of laparoscopic myomectomies. Back then, very rare for somebody to do laparoscopic myomectomies. And I was with him all the time. And he's actually still in my life. He's been at every single milestone of my life. Older white guy in New Jersey. I don't know why he took to me, but he has really encouraged me. He encouraged me to think about fibroids as something that I wanted to take care of. And I was 23 years old when I met him. And fast forward to when I was 33, I actually had fibroids. And at that point, I was a fibroid specialist. That's all I took care of. And so I didn't know 10 years prior, when I decided that was what I was going to do with my life, that I actually would be personally affected by this. So he was my first mentor. My second mentor is that I want to talk to you guys about is Dr. Christy Walker. She's a Black woman. She's the first that I know of, Black OBGYN, board certified OBGYN, they did a fellowship in cosmetic surgery and opened up the door for us, right? The American Academy of Cosmetic Surgery is different from the American Society of Plastic Surgery in that the American Society of Plastic Surgery, plastic surgeons do cosmetic surgery, yes, but they also do hand, cleft palate, burns, wound care, all of that. We don't do that. We just do cosmetic surgery. And my fellowship is one of two that is facial and general cosmetic surgery. Every other cosmetic surgery fellowship is either facial or general. Mine is dual accredited, and that's the only way gynecologists can get in, because gynecologists are only eligible to do general cosmetic surgery. So I do things from rhinoplasties to blepharoplasties, facelifts, breast reconstruction, breast surgery in general, body contouring, and genital cosmetic surgery. One of the things that really, really struck me is, I'm Nigerian. I guess everybody knows that from my last name probably, but I'm Nigerian, and in Nigeria, it's not that prevalent, but in other African countries, in the Middle East, there's a lot of female genital mutilation. So one of the things that I have learned to do is reconstruct and really help women who have a lot of scarring, who have a lot of difficulty with vaginal deliveries and things like that. So I sum all of this up to say that, my journey has been circuitous. It was not straight. A lot of people thought I was crazy when I had a very successful gynecologic surgery suite, that I closed it to really go after things that I know not only will have changed my life, the best career decision of my life, but also would impact women over time. So I practice the gamut of my practice is I'm an OB hospitalist, 2 shifts a month. I'm a gynecologic surgeon. That's what I do. And I'm a facial and general cosmetic surgeon. So I hope that you guys learned a little bit from my story, but I can't wait to share more.
That was lovely. And I just can't wait for our audience to be able to ask you questions. We just have such a great group tonight. And your story, it just shows that it's possible to go one direction and still have dreams to pursue after residency. It's not an end all be all, but just another way to go to a different direction and a different path. So with that, Dr. Lewis, we'd love to hear about you and have you on the screen.
Yeah, so my name is Ari Lewis. Thank you guys for having me tonight. Sorry for the delay. I was coming from other obligation. But first, you guys have an awesome, diverse, good mix of a panel here. So I went to medical school at UT Health Science Center in San Antonio. Decided to stay there for residency and ultimately graduated last summer and stayed on as generalist faculty. So why I chose OBGYN, I grew up thinking I absolutely wanted to be a pediatric orthopedic surgeon and nobody could tell me otherwise. And then throughout medical school, that's what I thought as well. And my second to last rotation was obstetrics and gynecology. And I remember the first day just being floored, working in the OB emergency room with just the crazy things that came through. So placental abruptions. Somebody else earlier said that it's like working on a trauma unit. I think Dr. Cope, but it's just a good variety. You have to think on your feet. I had no idea it was so much surgery, which you can kind of make of it what you like. But I love operating. I have 1 or 2 ORs a week, which is phenomenal. You have continuity of care. So I have one patient who I delivered her first baby when I was an intern in residency, and I just delivered her 4th baby this past week. And now we have a lifelong relationship, which is phenomenal. Other things that I think the other question was, who are your mentors? So my biggest mentor is Rochelle David. She's a generalist who I worked with when I was a sub-I on my gynecology rotation. And she took the students under her wing and just really pushed us as female surgeons. You guys are phenomenal. You can do whatever you want to do. And was just extremely supportive, always available. And then my other mentor's name is Luke Newton. He's the head of our generalist division. And so I guess I have a little bit of a different perspective in that I work in academics, and that's what I'm most passionate about, whether it's teaching medical students or teaching residents. So these mentors that I have really made a big push to figure out what I want out of this position, and what would really make me happy. So I'm in my 2nd year as faculty, and I'm the assistant clerkship director for the 3rd year medical student rotation, which I love, just getting them involved in clinical care, showing them how awesome our specialty is and all the routes that you can go. You guys heard about maternal fetal medicine, GYN, oncology, reproductive endocrinology and infertility, minimally invasive surgery. So there's a lot of different routes, hospitalist medicine. You can make of it what you want. And my big thing was I wanted to be in academics. So I got to do that. I teach 1st year medical students every Friday morning in clinical correlation cases. So that's phenomenal. So I get that aspect of getting to work with medical students and mentor them and get them excited about our specialty. And then the other thing is just the breadth of things we do. So I have, again, 1 to 2 OR days a week. I'm on labor and delivery 1 day a week. And then I have 2 days in my private clinic seeing patients. So it's a good variety. You get to be motivated, love what you do, care for your patients. So that's kind of my perspective as a academic generalist.
That's a really wonderful perspective. I'm glad we have so many different groups here today to be represented. And I guess just to get started, can you guys think back to that transition between medical school and residency? And how was that for you? In that transition, what are some things that you learned about yourself over that year? And before we get started, I just want to make sure the audience knows to put your questions in the chat. We have a hot group tonight, so definitely get your questions answered.
I'll start if that's okay.
Yeah, definitely.
That transition is no joke. It's amazing. So I did residency at Spectrum Health, Michigan State University, and it was like number 7 or 8 in the country for obstetric volume. It was like 11,000 deliveries a year, right? So our triage had 19 rooms. Our L&D had I think it was 30, 35. We had another floor that was just high risk patients.
Yeah.
And so I say all this to say, it's just craziness all night. You're just running all the time. And you're running in such a way that oftentimes we would find ourselves in situations that you didn't feel necessarily prepared for. Day 2, postpartum hemorrhage, right? And they go, "Doctor, what do you want to do?" And I'm, and so the thing is, I learned that I have an okay poker face. That's one thing. Second thing, I learned that I think the way that I prepare actually works. I really try to mentally see the worst possible scenario even before I get in the hospital when I'm studying. And so I found out about myself that with that poker face and with that study, I can enact it and I can fake it till I make it. And I think that's a big part of that transition. You may not feel, and you probably shouldn't feel like you know what you're doing, because you don't. But what you can do is prepare as much as the books, keep your eyes open, keep your ears open. And then when it's game time, when it's time for you, understand you are controlling that room. All eyes are on you. As you go, they go. So I learned to put on that poker face. I learned to fake it till I make it. But of course, always call for help if I needed it. That's how my transition was.
Yeah, definitely.
So that it feels like PTSD, like trying to go back there. So when you're a medical student, or I don't know about y'all, but when I was a medical student, I thought I was thinking that when I went on labor and delivery, I was going to be MS5 that can write prescriptions, like nobody's going to ask me to do, like, there's got to be graduated response. They cannot throw me in. These are real people. I trained at Georgetown, like I said, but Georgetown is actually a really sane place. The university hospital, you might have one or two patients here and there. They come in with their Louis Vuitton luggage. They're all 41 with twins because they're IVF, and they are, but they're all sick because they're 41. But at MedStar Washington Hospital Center, you are in the middle of DC, Chocolate City. It is. I remember like going through like 19 hours and not peeing. And when I peed, this is TMI, but I'm gonna tell y'all anyway, I looked in the toilet, it was like Coke color. It was like, I was so dehydrated. I said, I'm gonna give myself a UTI up in here. But yeah, it was a lot. So my point is, Dr. Cope was giving you guys the poker face. I was giving the bewildered, like, why am I here? And can you save me, please? But I will give you the best advice. This is what I learned. A couple of things. First of all, I didn't know nothing. I went home so tired. I never studied. I don't know how I got through. But I learned a couple of things. Number one was the nurses, the older nurses, particularly the Black nurses, would always basically be like, so you want a 2.0 Vicryl on a CT1? I was like, oh yes, I want a 2.0 Vicryl on the CT1. They realized I was struggling and they babied me. The other thing is I was always eager to work. So the way that we were set up, there was always a back room where everybody would sit and gossip about the patients and, gossip. But they were giving patient care, but there was a lot of gossiping. I was never to be found. I knew, like, my chief would be like, there are 2 patients on the board. I'd be like, yes, there's a 17-year-old G1P0, 37 weeks. Like, I already knew because I was always in the front. The other thing is I didn't know how to give presentations. I am a podcaster now, so I know how to tell stories now. But the reason why I podcast is that came from the fact that I have a speech impediment. So I stuttered a lot. And you probably can't tell because I worked so hard at it. But so when I would give presentations, this is how bad it was. Dr. Tamika Augusti, she's the vice chief at, I guess, assistant chief of OBGYN. She's a Black lady. She was the type of old school love where they beat you over the head and then they tell you, I love you, that type of love. So she told me one day, she came by and whispered to me, and she said, you ain't gonna let these white girls beat you. Like, you need to get your shit together. Because I couldn't really present. So what I used to do is I would stand in front of the mirror and I would make myself present a whole presentation over and over and over. I didn't know how to tie. Your girl would be tied. Somebody once stepped into my car and asked me if I did Nigerian voodoo. Because I had like a whole bunch of sutures around my wheel that I was tying at every stop. Like, but now, you tie like there's nothing on the back of, and I'll tell you what happened through that. I wrote a journal. I look back at my journal. I said, girl, you went through it. But I used to write a journal about, it was always a critique of my progress. And I look back, and when I switched from OBGYN, where we operate in a pot, which is the pelvis, to going to operating in planes, I was hacking. I didn't understand what my brain could not make the transition. Or you're a laparoscopist, you operate like this. You're a liposuctionist, you operate like this. So like my brain could not make these mechanical shifts. So at my big age, I went back to my intern year, and going back and looking at my journal, my diary, I realized that I got through that and I became an expert in that. So then I could do anything. So in all of that, intern year for me was the most formative year, because as crazy as you look, because you look crazy, you will get better. It will get better. There's no way out. There you can't go. You can't unless it's below you. You gotta go up. So I will encourage you, if you feel like you don't know what's happening, you don't, but you will.
Man, I listened to these stories about the transition. I agree. Zeb painted Dr. Cope in such a lovely way, but for me, it also is a little bit of PTSD. I'll try to marry the two experiences because I do think there are some positives along with the struggles. The first thing I'll say is that transition from medical school to intern year teaches you a lot about your weaknesses. Like if you didn't already know it, it will highlight them 100%. I am not a details person. I'm a big picture person. And let me tell you something, it doesn't matter what kind of person you are when it comes to intern year, you need to know details. Like you're managing a lot of small tasks and especially in OBGYN in so many places. So you have to be able to keep those straight. It's not my strength. Okay. I fully and wholeheartedly admit it. And that would show up in so many different ways, right? Like you're managing labor and delivery, the postpartum page is going off. Next thing you know, they're calling your chief like, hey, where's your intern? We've been waiting for a colace order for hours. It's like, I don't know. I didn't prioritize that over the vaginal delivery that was happening just down the hall. Like, I don't know. How do you manage this? Similarly, in presentations, similarly, I like to talk. I don't mind public speaking, but when it came to a presentation about a patient with preeclampsia, that's a complicated patient, especially for an intern who's just starting. And for some reason, I would watch my co-interns, there was 2 of us on labor and delivery, give that presentation, and it felt like relatively seamless. And I'm like, damn, I think I'm a smart person. Like, I feel like I have some kind of handle these things, but my presentations were all over the place. And it was obvious and it was glaring. And another thing, I'm Nigerian. I'm not the most timely person, but like when it comes to medicine and like especially surgical subspecialties, like there's no, like we need to start rounds at 7 a.m. so we can be at our first C-section by 8 or be in the OR by 7:30. Like when you're 2 minutes late in Nigerian time, that's fantastic. You're like early, but in surgical time, that is, you have really eaten at the clock. And while it's hard to hear and see full front the things you're not good at, it's within your power to change those things and to adjust those things, right? And you shouldn't take it as, it's easy to say like, wow, how come everybody else can do these things, but I can't? But there is a way to change it. I located, I think she was a third year at the time, who just like, when it came to managing tasks and like having everything in order, she was on top of it. It was like a beautiful skill. I sat her down, we were on labor and delivery one day. I said, hey, I'm struggling with, being able to manage and check off all these tasks. Like, what's a way you tackle it? How do you approach it? I located like 2 or 3 people who I felt comfortable asking, who were senior to me or who were my year. And I asked them how they did it. Not everybody's strategy is going to work for you, but like hearing different ways and finding and trialing, you will never find me giving up on figuring out the solution for me. And it's okay if it takes many iterations. It's okay if I embarrass myself in some of those iterations, but I'm going to find it and I'm going to get it. So just know that's within your power. Yeah. While intern year in that transition highlights your weaknesses, the one reason I was able to not say, wow, man, everybody else seems to be getting it, but I can't, is because it also really highlights your strengths. And it's easy to not pay attention to those, but like when you see those, grasp them, hold on to them, and let them keep you going. I would be in a patient's room talking to a patient about the labor progress and, you know, the transition from Braxton Hicks to like, you know, real labor contractions. And I overheard one of the nurses, one of the older nurses, like old time, been there for a long time. And she was talking like, who is this doctor? Like, what year is she? They're like, oh, she's like one of the new interns. And I'm like, oh my God, like she's like the way I would connect with patients, be able to explain more complicated concepts to simpler concepts, the way I related to the nurses. Many interns and residents have sometimes negative experiences with nurses, like, oh, they're hazing me. Like, I don't know why they're so mean to me, but like, I would relate with them, treat them with respect. Like we would have great one-on-one conversations, get to know them well, and they loved me and they were always looking out for me. So like being able to connect with people, like that seems like not a critical skill because especially in medicine and academia, it's always heightened against things that are quote unquote more objective. But that was a strength of mine that carried me and still carries me to this day. So I held on to the fact that, you know what, this may not be my strength, but that I can change. And nobody has it perfect. So try to hold on to your strengths as you're seeing and working on your weaknesses.
This is great. You guys have such wonderful advice to give. Did you want to jump in there, Dr. Lewis?
Oh, I was just real quick. Like I'm getting palpitations just thinking about being an intern all over again. It's like, you know, you finish your sub-IA, you're like, yeah, I'm matched, I'm hyped, I'm ready to go. I'm about to do this whole residency thing. And then you get there on day one, like y'all are saying, like you're getting pulled and yes, mind blown. You're getting pulled in all the directions. You're like, yo, my mom told me I was good. I was going to be prepared. I'm going to be a good doctor. And it is overwhelming. Everybody will talk about like they equate it to drinking out of a fire hose. But the important thing is regardless of what specialty you go to, regardless of where you train, everybody's going through the same thing. You've never been a doctor before. So I think it's having that insight that, yes, I am struggling, but I'm supposed to struggle, right? I've never been a doctor. I got to learn how to write notes the right way. I got to learn to put in orders the right way. While you're going through it, you don't have that perspective. It feels like, man, I'm garbage and I got to figure out how to be better. But, you know, just that insight that we're all on the same page. I've never done this before. I got to take everything, all the feedback that I'm receiving, learn how to take this constructive criticism and realize, even though a lot of us are type A, that I'm not perfect. I got to learn how to adjust my technique, my strategies, whatever I'm doing as I approach residency. And just know that everybody goes through it, just like you go through it when you become a third year. And you just got to adapt and keep it pushing.
All wonderful, great advice. And I think the audience is also feeling that too. So let's.
Looks like she was disconnected. I'm the host. I'm going to take over. So what I was, oh, never mind. Excuse me.
I have no idea what happened there. Sorry about that. Let's get to some of the audience questions. Let's start with our VP right now, Rachel. She asked, any general interview tips for us applying this cycle?
Yeah, I'll go ahead and start. I'll say, I know it's virtual again this year. Stay true to yourself. I think a lot of times we're like, oh, you know, what does the interviewer want to hear? What does this program want to hear from me? You'll find your match. You'll find the place where you fit in. These are my people. So stay true to yourself. Be enthusiastic. Be genuine about why you want to go to a program, what you're looking for. Not everywhere is going to be the perfect match, but when you find that place, you'll know it. And let your personality shine through. It's difficult to interview virtually and let people know, you know, who you are and why you should stand out and be a member of that residency program. So let your personality shine through. Let them know who you are and why you should be a part of their program.
Yes, definitely. I think, yeah, definitely showing your personality, and very similar to how you applied to medical school, but perhaps more targeted in the field of OB-GYN. We do have more questions, so if anybody wants to answer that one, let me know. But for the most part, I would like to go on to the next question from Jessica, which is kind of similar to another question we have in the audience as well. As a first-year medical student, or in general as a medical student, how can I prepare for a future in OB-GYN? What can I do now to be competitive in that specialty and just to prepare to be successful? Yeah, go ahead, Dr. Cope, I see you.
Study. So the best thing you can do as a first year, quite frankly, is be in those books, be about your books. I would say also, and this is something I did not appreciate, is to build your support system and your emotional resilience. Build your support system and your emotional resilience. With that being said, on that note, I'm going to recommend a book called Anti-Fragile by Nassim Taleb, Anti-Fragile. With the context of how to build your social system, how to build your perseverance, because OB-GYN or any of the medical specialties are going to, it feels like they're trying to knock you off of that. And it's really important that you have support systems so that on those days that you are not a good doctor, on those days that you are quite a failure, you have the mindset and the resiliency to go home, study, and bounce back and be ready to rock the next day. So I would say that's one of the best things, study and build your support system and your emotional resilience.
Definitely. I am a first year myself, so I can attest to that. I think I'm studying right now for pit stop next week, but definitely very helpful. We do have another question from the audience. I think this would be a good one to ask from a past FLP alum, China. Dr. Cope, how do you incorporate OMT into your practice? Also, what were your favorite resources in refining your skills?
So it was a little bit difficult. I'm an osteopathic physician, but I went to an allopathic residency and fellowship.
Okay.
When you go there, unless you have a DO as your faculty, a lot of the things that you could do, you can't do in front of them because they can't critique it. They can't critique what you're doing. So a lot of what I did was muscle energy, relaxing things, especially women that had pelvic pain as they were getting more pregnant. There's a lot of the more passive things that we could do, things especially like the suboccipital release. Oh my goodness, every woman that came in like with a headache later on, a suboccipital release, and it was like wonders. It wasn't the breadth of OMT that we're exposed to. You just really can't. I couldn't do that in allopathic because no one could critique me. But doing those small things made a big difference in those patients, and it really helped with the rapport as well. You know, someone comes in, they've had this like headache, and their blood pressure is normal for weeks, and you just do a simple thing, and they're like looking, and they're like, it's gone. You're your best friend after that.
Yeah,
so.
That's great.
So
Another question.
I'm in the
Oh, go
same boat.
Yeah.
I'm a DO, but I did allopathic, everything else. So when I started my practice, I realized that they're in the Dallas area, every OBGYN sort of brands themselves in some way. So I was a fibroid girl, but I had a lady who was a chronic pelvic pain lady, and she was an MD, and she was like, hey, do you know any of these OMT for the pelvic floor? I was like, I don't know that, I can't remember. But then I remembered that my one of my professors has like a little refresher clinic. So we signed up and I went with her. And they also have some refresher clinics at Harvard, just weekend courses. It's not for just DOs, it's for DOs or MDs. And so you can go and just learn specific to your specialty and what can help your specialty. So I did that. And then I asked her to help me with lymphatic release because I knew I was going to go to cosmetic surgery. So I learned that. So the lymphatic effleurage. So I use both of those in my practice. And that's a way to refresh yourself. Obviously, you can buy books. If you are OMS, you already have like the basics, right? So you know how to use your hands. I think that for me, the advantage of being a DO is I can conceptualize, you're taught to conceptualize structures that you can't see, and that's OBGYN. Like you can't see inside of the hole called the vagina. So half the time you're trying to conceptualize stuff. And so for me, I already had that, and you use your hands a lot. So you're checking cervixes. I remember the other first year residents were like, I don't know, but your brain sort of already has that. So I encourage you, if you're still in medical school, something I wish I did was pay attention, because I thought I was going to be a dermatologist, and who needs OMT in dermatology? I don't know. So
Great. Definitely. For all of our DOs out there, there is place and time for the skills that you do learn in school. So keep up with that and can potentially help your patients in different ways that you never thought you could. We do have a question from Laki, and I think this is an interesting one. People always talk about the negative work-life balance associated with this specialty. Do you feel as if you have accomplished a fair work-life balance?
I can jump in on that one. Two comments in that regard. One is that, as you've heard from everybody on this panel, this field is so incredibly diverse.
Mm-hmm.
You can be a generalist, an academic generalist, do the full range, the full gamut. You can subspecialize, super subspecialize. Like, I'm a maternal fetal medicine specialist, and I happen to stay in academics and do occasional labor and delivery call, but there are maternal fetal medicine specialists who do consultations, like purely consultations and ultrasound and prenatal diagnosis, and don't have to take a labor and delivery call ever in their life. You know, like you heard Dr. Cope talk about urogynecology, the work-life balance and the lifestyle can be a little bit different. So I wouldn't be afraid of how the specialty can dictate your lifestyle, because there are ways to navigate that and tailor it, whether you decide to stay obstetrics, whether you decide to stay gynecology, doing both, whether you stay in academia, private practice, you know, go kind of, you know, if you have other interests, more public health regarding. So I think it just depends on what you're looking for. You can always find something that can fit your life a little bit better. The second thing is, if you talk to anybody who knows me, they'll be like, UK is always out and about and here and there and traveling. And I would be the person, I don't highly recommend this, but I would be the person in residency who would be on a 24-hour call the next day and go out the night before. Like, but that's just my personality, right? Like, you know, never anything crazy that let me compromise the next day. You still got to use some judgment, but like, I'm not missing an event. I'm not missing a trip to Nigeria. I'm not missing a trip with friends. If I can fit it in, sometimes I'll sacrifice a little sleep, but that is okay for me. My sister, don't play with her sleep because she's not functioning the next day, and you're not going to like it either. So like, you just have to know yourself and know what works for you. So, you know, for me, and I found, you know, a job that allows me protected time to do research, which also allows me some protected time to work remotely and travel, but also still do labor and delivery, still do prenatal diagnosis. I think because there's so much that this field has to offer, it's actually easier than you think, and especially in modern times, to find something that works for you and suits you.
I want to piggyback on that because I think OBGYN is a microcosm, sorry, Dr. Cope, of what happens if women rule the world. Okay, let me start there. Because now you know that most OBGYNs, 9 out of 10, are going to be women. And why do I say that? We want to have babies. We want to we want to go to the soccer games. We want to cook our husband's meal or ourselves. So there is I think that, you know, OBGYN has changed in that regard in a lot of ways. It allows for people to work in different practice settings that allow you, like I have a friend who is one of 15. My best friend, she's one of 15. She takes call once every 15 days. She does not, and she works 7 to 3. She doesn't have kids, but she doesn't want you to know that. She just wants her time. So she's going to pick up her imaginary kids from wherever they are. Okay. So she leaves her office. Do not put a patient after 2:30. I am different. I believe that work-life balance, one day the balance will come, but right now I got to work because I like Hermes. So there's a big difference. So I was on call for 700 days straight. Why? Because I own my practice. So I was on call when I was in Sierra Leone. I was on call all the time because of that. Those are my patients. You might not want to do that. You might want to be like my best friend, and it allows for that, right? And so that's what I say. Now, residency, nobody can lie to you. Residency, I think OBGYN residency is worse than every other residency, even though I've been not in any other residency. And I think we should be honest about that, because if you are in general surgery, you operate on 3 people, you round on 3 people, and the other 3 people that had complications. If you're OBGYN, if you deliver 50 babies, you see 50 babies. 50 moms before you start your day. So many of us can attest to being interns at the hospital at 4 a.m. mainly because we didn't know how to flow, but because you had to see patients. So I can't lie to you that the residency is trash. But when you finish, you get to decide how you want to live your life. You want to be nuts like me, come along, we'll be fine. I'm still okay and I still don't have pimples. But if you want to live the good life, you can be my other half. So sometimes I have this alter ego that only does OB hospitalists. Okay. So I work 5 shifts a month. Do not call me after I leave the hospital. Okay. And I will be in Paris tomorrow or Madagascar the day after. But I do my 5 shifts and that's all you get. And so there is a gamut of what you can do with this specialty. Personalities are all accounted for. If you like to look at pictures and you can deem yourself a radiologist, but you want to be an OBGYN, go over to Dr. I keep wanting to call you a Merriway. I don't know why.
Close, Merriway, close.
Yeah, no, I'm so sorry because I had Dr.
Name is so
Go and look at all the ultrasounds with her.
Right.
If you want to be the badass surgeons, go to Dr. Cope's land or my land, and we will robot the robot. Okay. And so whatever, I mean, and by the way, I must talk about some unique things about our field. We are the only people that take care of 2, 3, 4 humans at the same exact time. Number one. Number two, we're the only people that operate in multiple orifices, okay? With using multiple things. We go through the vagina. We do rectovaginal fistulas. We use everything from radio frequency energy to we do our own 4D ultrasounds, okay? I know how to do them. We be popping. So I just need to tell you that.
This is great. Dr. Lewis, I think you're talking, but you're on mute. Oh, no. Okay. We are at time, but I just don't want this conversation to end. I see that there are lots of questions in the chat. So if you didn't get your chance to answer your question, definitely reach out. I think this group will be more than willing to answer the questions you may have. And I see Dr. Cope, you brought your son along. He's so cute. Let's end with words of wisdom. Yes? Let's go around and say, what words of wisdom will you give to our audience today? Mind you, we do have people from first-year medical students all the way to people who've already turned in their URAS application looking to be you. So what words of wisdom would you give them?
I'll go ahead and go first. I think be motivated and believe in yourself. A lot of times throughout medical school, you get knocked down a little bit and start to doubt yourself or get frustrated. But you made it here for a reason. You're in medical school. Someone believes in you. You should believe in yourself. Remain motivated. And then the other thing is remember to do what you love, right? So outside of work, if you like doing ballet or if you like playing piano, like do that. You should continue to do what you love. Spend time with your family because you do have a life outside of medical school, outside of residency, and those things are important to maintain your wellness, happiness, and overall perspective on life. But you're capable and you can do whatever you want.
Perfect. Thank you.
I'll say my probably best piece of advice is try not to get distracted by the noise, whether that's praise, whether that's criticism, whether it's constructive, whether it's unjust. And just if you focus on every day figuring out if you can do the task that's being asked of you better, you're in the right place. So whether you're a medical student and someone asked first year, what can I do? I like that Dr. Cope said, study. Like look at your books, do it well, especially these days. Like it's so hard because so many people are doing 50,000 different, extracurriculars, which are like, they're important. I'm not going to lie. But if you're the kind of person who wants to take on one and do it well so that you can also study well, do that. In residency, you're going to get critiques. It's going to be hard because it's going to come fast and it's going to come a lot because like Dr. Arumala said, there's a lot you're still learning. But if every day you just go home and ask yourself, you know what, that may have made me feel XYZ way, tap into your support system for that. But can I actually do that task better? Like, is there a way for me to focus on doing it better? Then you'll never go wrong if you focus on being the best medical student or being the best physician to your patient, to do what's best for the patient that you can be. So, you know, I always say, like, I may not be the smartest person in the room, but you're not going to outwork me. I may be in a different city every other weekend, but you're still not going to outwork me. Even if that means me staying up till 3 a.m. because I wanted to be in a different city every weekend, you're still not going to let it see my work suffer, because the one thing you won't be able to tell me is that I did not do a good job keeping my patient safe and making sure I care for my patient and protecting them in that relationship.
So I have two advice, and because I think that they're so important, I can't choose between the two. The first is you will fail at 100% of things you never tried. You'll fail at that. So for people that, you know, you feel like, man, I really want to do REI, but everybody tells me it's so competitive. Well, you just told yourself no if you never applied. You'll never be at REI if you never apply. So my point is, go for it. Try. If you want to go to Harvard, if you want to be like Dr. Marwa and be like Ivy League down, then you need to apply. Because if you don't apply, I can guarantee you will not be Ivy League down. And then the second
just real quick before you pop on your next thing, a testament to that, I was told in medical school that I probably was unlikely to match at Brigham Mass General. I'm going to apply anyways. I'm going to do it. And then look at it. So thank you for that word.
Yeah. And then the second thing that I want to share with you guys is we had a lot of distractions, but the distractions were physical and spread apart. You have the distraction of wanting to be a med school influencer, wanting to be a this and a that and a this and a that. And your TikTok friends are making money off of it. But I will tell you that if you get distracted, the time that you spend doing the things, the co-curriculars or the other things takes away from the main thing. My mother always used to tell me, don't go chasing things that don't pay the bills. Stay focused. Everything can be done, but they can't be done all at once. So stay focused, because when you have that doctor on this, people will pay you to talk to them. People will pay you to do your job. People will pay you for what's in your brain and what your hands can offer. And if you spend all your time and you fail, you'll never get there.
Yes.
I think everything has been amazing. But you're going to take time to be the best surgeon you're going to be. You're going to take time to be the best obstetrician you can be in residency. You're going to take time to be the best clinician. This is harping on the point I had before. Residency has a way of potentially making you lose your way because you're not taking time to build yourself spiritually, build yourself support-wise. I say this and I harp on this because I was a gunner. Dr. UK, you can't outwork me. It's not possible because I'll die in here. I was there before you. I was here before you. I didn't even go home. You can't outwork me. So, but in the process of that, keeping it, honest, I suffered from great depression during my fellowship. And I think that's why I speak so much about that emotional resilience. That's why I speak so much about building your support system. That's why I think it's really important as you're studying, you do pick up the phone and you call your friend every now and then. You say hello. You do pick up the phone and you call your mother. You do try and make that family event. I think it's essential because you're trying to be a whole person as a physician. So gun hard, study your butt out. Don't let anybody outwork you, but don't lose your soul. Know who you are. Take the time to stay a human being, because that's going to be the thing that saves you when the things in your head say, I can't do it. I'm no good today. Maybe I'm not a good doctor. What's the point? Because we're also focused on medicine. Yeah. Like it's us. It's our identity. What happens when that identity is shattered a little bit? you have more. You have more to yourself. And also just gives you the resilience to come back and fight another day. So if I had any last words, it's okay. Keep grinding. Build your support system.
Yes. These doctors were dropping gems. I hope you guys were out there picking them up. This was wonderful. Our Sowing Seed specialty series for Obgyn could not have been any better than what we had tonight. So thank you so much. Thank you for everybody who joined. And thank you for our SNMA for hosting this. We will be continuing more Sowing Seeds next Wednesday. So be in the know, stay tuned. Follow the SNMA at SNMA_official. That's our IG, and Twitter at SNMA. And if you're not a member yet, what are you waiting for? SNMA has so many wonderful programming that members who are members have access to. I wouldn't miss it. Join the SNMA and continue coming to Sowing Seeds. We could not be more happy to have you here. Have a wonderful night, everybody. Bye. We'll talk to you later.